Thank you, Chair Dean and members of the committee. My name is Alec Mendoza, and I'm a Policy Advisor at Texas 2036. I'm here today to talk about the ACA Marketplace enrollment here in Texas. We have 4 main takeaways, as well as to talk about how Texas can build off of a federal billing transparency reform. Before we start, I want to thank the committee for a robust conversation on an extremely important issue, and want to highlight one particular panel, and that was the TRS panel. I think this conversation becomes really important when the state is the payer for healthcare services and those healthcare prices, and so that was one particular thing that they highlighted that I think was really impactful. So to start, I want to focus on our headline and our first takeaway, which is Texas bucked the national trend. Nationally, ACA enrollment fell by about 1.2 million people in 2026. Texas went the opposite direction. We had about 200,000 individuals in our marketplace this year compared to last year. And so our ACA enrollment was about 4.17 million, and that 200,000 actually was leading the country numerically, and so we had higher enrollment than many other states. Takeaway number 2, shopping actively in the ACA market had a measurable price tag. Texans who returned to the marketplace and shopped for a plan had an average premium of about $66 a month after subsidies. Texans who auto-re-enrolled, they were passively renewed into their previous year plan, saw an average premium of $145 a month, more than twice. And so that $79 monthly gap adds up to about $950 this year. And so that is the price tag for simply not engaging with or shopping in the market. Takeaway number 3, Texas chose Gold. Gold was the most selected tier in Texas this year at 41.3% of enrollees, and that makes up about 1.7 million Texans who chose that coverage option. After subsidies, Gold plans averaged $86 a month, and 59% of Gold enrollees are paying less than $10 this year. Takeaway number 4, how did Texas get here? The answer is Senate Bill 1296, a bipartisan state law by Senator Nathan Johnson and Representative Tom Oliverson that passed unanimously in 2021. The law directed the Texas Department of Insurance to optimize the federal subsidies for ACA Marketplace plans by aligning premiums across coverage levels. The result was Texas benefited more from federal subsidies than many other states, and that was reflected in our bronze and gold plan prices. Something that I want to point out is we had a lot of conversation around silver loading and Senate Bill 1296 this morning. This particular bill was something that we were leading on here in Texas in 2021, and we would be happy to sit down with any offices and staff afterwards to kind of talk about the nuances and complexities of both silver loading and Senate Bill 1296. Something to watch for. We already talked a little bit about effectuated enrollment, and I think that's a number that is important to think about going into the rest of the year. But a population worth watching is the significant share of Texans who were auto-re-enrolled in that specific cohort. They were in silver plans, and they were most likely in plans that cost $0. And with the end of enhanced subsidies, that premium for those silver plans went up. And again, those folks were auto-re-enrolled. And so that specific cohort, about 69% of them fall between 100 to 150% of the federal poverty level. So they're very sensitive to any type of premium increase. And so I think something that's really important is what happens to that population during 2027 in open enrollment. A lot of those folks are probably still eligible for a low-cost plan or even a free plan that is bronze tier. And so it's really important to think about how that specific population impacts our 2027 open enrollment and our uninsured rate. Kind of going back to the ACA and thinking about ultimately, this was a story of transparency and structure. When Texans have the right framework in place and the right information to make decisions, better outcomes followed. And that kind of leads to the second thing that I want to talk about today, which is how Texans are billed for care. And so that's on the back here of this sheet. So when hospitals acquire physician practices and reclassify them as hospital outpatient departments, they're allowed to charge a facility fee on top of a physician's fee. To illustrate, a Houston family had their type 1 routine diabetes visit for their child go from $90 to $600, simply because a hospital ownership change triggered a facility fee. So here's where the transparency gap comes in. Off-campus clinics bill under the main hospital's National Provider Identifier, MPI, a unique 10-digit number that is provided to healthcare providers and facilities. When a hospital outpatient department bills under the main hospital's MPI, that facility fee is charged, and as if the service took place on the main hospital's campus, even when it may have taken place down the street at an off-campus clinic. And so the bill reflects that it happened at the hospital rather than when it happened at the off-campus clinic. So because of that, payers can't distinguish between a routine office visit from a main campus procedure, leading to a payment reflecting where the care took place rather than what care was provided. And so this billing practice can create a transparency gap that may impact competitive dynamics here in Texas and fuel an incentive for hospitals or private equities to purchase independent practices. Congress recognized that this was an issue, and they acted. In the most recent federal funding bill, off-campus hospital outpatient departments are now required to have a unique, separate MPI for Medicare claims. And I think this is where a gap comes in. That federal requirement was only for Medicare claims. So we now have a two-tiered system. Medicare claims will reflect the true site of care. Commercial claims will not. And so Texas has an opportunity to close that gap. The legislature could require off-campus hospital outpatient departments to use location-specific MPIs on all claims, not just Medicare. This builds directly off infrastructure already in place, as the federal bill already requires them to have that unique MPI, and requiring this would give Texas patients, employers, and payers the billing transparency the market currently lacks. So members, in closing, both of the topics raised today come back to the same principle. When the market has the right structure and the right information, Texans are better positioned to make sound healthcare decisions. Thank you, Mr. Chairman and members.